Good evening friends, this is Dr. Chaitanya again and welcome to my channel Critical Care Basics. In this channel we are running ECG tutorials and this is the part 3 of our tutorial on atrial fibrillation. In last two tutorials we have discussed about the mechanisms of atrial fibrillation, the clinical features and the management stroke prevention. We discussed about the ABC of management of atrial fibrillation. The A was predominantly stroke prevention. B is regarding the rate and rhythm control. So in this lecture we are going to discuss about the rate and rhythm control. Rate control means the patient continues to have atrial fibrillation. He or she does not have a sinus rhythm, but the target of the treatment is to reduce the ventricular rate. While in rhythm control, the target is to achieve a sinus rhythm. So when do we prefer and which therapy is to be given? So let's discuss some points regarding the rate or rhythm therapy in atrial fibrillation. Now, what happens to a patient who comes in acute cardiovascular care or who comes in an ICU or emergency department with AF? Right. So first check whether the patient has a fast ventricular rate, AF with fast ventricular rate. That is defined by a ventricular rate of more than 120. If the patient does not have fast ventricular rate, then consider bystander AF, no immediate treatment is required as far as AF is concerned. If the patient does have fast ventricular rate, then step 1, is the patient hemodynamically unstable? If yes, then this becomes the class 1 indication for electrical cardioversion. If no, the patient does not have hemodynamic instability, then get a 12-lead ECG, step 2. Then step 3, does the ECG show WPW, that is pre-excitation in addition to AF? If yes, then better to consider cardiological consultation. If the patient has hemodynamic instability with AF and WPW, then the treatment of choice is cardioversion. Remember to avoid drugs which slow the AV conduction like beta blockers, calcium channel blockers and amiodarone. If at all you want to consider pharmacological cardioversion, you could give ibutylide or propafenone. Step 4, if the patient has AF with pulmonary edema, that means patient has heart failure, then rate control therapy should be preferred. If the patient does not have heart failure either, then you have two choices. You could consider rate control or rhythm control. If the patient has an AF of less than 12 hours duration with no previous history of thromboembolic episode, or the AF is 12 to 48 hours of duration but the CHAD2D VAS score is less than 1 for men and less than 2 for women, then again that becomes a class 1 indication for cardioversion. If you do not know or the patient does not satisfy these criteria, then rate control is recommended. You can use beta blockers or calcium channel blockers and anticoagulation, IV to oral bridging therapy. We have discussed about IV to oral bridging therapy in our last lecture. So this is how we treat a patient who comes to our emergency department with AF and fast ventricular rate. Now there will be slight repetition because I want to drive these things home. So please bear with me. How do you do direct cardioversion in a patient with AF? This is the electrical recording, ECG recording of a patient who had AF with fast ventricular rate and was given a synchronized shock and the patient has achieved sinus rhythm. So cardioversion is indicated in hemodynamically unstable patients when the pharmacological cardioversion has failed, right? Use a biphasic current, biphasic defibrillator and a synchronized current which synchronizes with the R wave. Because this is an irregular rhythm, you have to use a higher strength of current, 200 or 150. If the patient has a pacemaker, then your electrode placement should be at least 8 cm away from the pacemaker. It is better if you have a facility for transesophageal echocardiography to rule out atrial thrombus, or unless the patient has less than 48 hours of air duration, or the patient is already on anticoagulant for last 3 weeks. Before giving a shock, give unfractioned heparin 60 units per kg or low molecular weight heparin 1 milligram per kilogram, and also sedate the patient giving midazolam 0.15 milligram per kg. Pre-treatment with these drugs could increase the success rate of your shock. Amiodarone could be used, ibutyllite, sotalol, flecainide, propafenone. And if you suspect that the patient has additional 6 sinus syndrome, then put in a pacing wire, or you can use external pacing. Again, cardioversion in AF. If the AF is less than 48 hours duration, right, then you can give heparin and directly go ahead with cardioversion. If the patient attains a sinus rhythm, then see for the risk factors. If there are no significant risk factors, then no long-term oral anticoagulation is required. If the patient after cardioversion continues to be in AF, you could use a drug which increases the success rate of AF, or if that fails, then you may switch to rate control therapy, or you may go in for ablation. If after attainment of sinus rhythm, if there are significant risk factors, then give 4 weeks of anticoagulation and calculate the CHAD2 DS2 VAS score and consider long-term anticoagulation. If the AF is more than 48 hours of duration, then either you could go in for the conventional therapy or transesophageal echocardiography therapy. In conventional therapy, give anticoagulation for at least 3 weeks and then do cardioversion under heparin cover. If the patient attains sinus rhythm, then give 4 weeks of anticoagulation followed by calculation of risk factors and long-term anticoagulation. If after cardioversion the patient continues to be in AF, then you have 2 choices: either add on some drug and retry cardioversion, or you may go in for ablation, or last is the rate control therapy. In the TOE strategy, do a transesophageal echocardiography. If there is LA thrombus, then therapeutic anticoagulation for 3 weeks followed by again repetition of TOE. If there is still thrombus, then consider long-term anticoagulation therapy. Cancel the plan to go in for cardioversion. But in TOE strategy, if there is no LA thrombus, then you could go in for cardioversion and the rest of the steps as we discussed just now. Now, cardioversion could be done by electrical means or by drugs. So, how do we decide and which drugs? If the patient has hemodynamic instability in AF, then you could go in for emergency electrical cardioversion, or if the patient prefers electrical cardioversion, even if the patient does not have hemodynamic instability, then could go in for electrical cardioversion. If the patient is hemodynamically stable, then see for the structural heart disease. If there is severe structural heart disease, then only drug which can be given is amiodarone. If the patient has moderate structural heart disease with ejection fraction of at least more than 40, then you can give intravenous ibutyllite or vernaculant. If these drugs fail, then second choice would be amiodarone. If there is no structural heart disease, then you can go in for pill in the pocket. This especially if the young patient, highly symptomatic and paroxysmal AF of very short duration, less than 48 hours, then the patient can take a pill in the pocket, flecainide or propafenone, or you can go in for IV, flecainide, ibutyllite, propafenone or vernaculant. Again, if these drugs fail, the choice would be amiodarone. These are the guideline recommendations for cardioversion. Pharmacological cardioversion of recent AF, excluding patient with acute coronary syndrome or heart failure. So the patient is young, acute AF means duration less than 48 hours, and no thromboembolism, no cardiac disease, then you can use vernaculant, propafenone or flecainide, class 1A indication. If the patient has heart failure or structural heart disease, then IV amiodarone cardioversion would be the treatment of choice, again class 1A indication. If the conversion to AF is recommended in symptomatic patient with persistent AF as a part of rhythm control strategy. So the patient has a persistent symptoms, lot of symptoms in a patient with persistent AF, then cardioversion is recommended, again class 1B indication. Pre-treatment, if you are to want to increase the success rate of conversion to sinus rhythm in cardioversion, then you could use pre-treatment with amiodarone, flecainide, ibutylide. The recommendation is class 2B. In select patients with infrequent or recent onset AF with no structural heart disease, no IHD, then you can take pill in the pocket, flecainide or propafenone. Recommendation is class 2B. And lastly, for patient with sick sinus syndrome, AV conduction disturbances or QTC more than 500, pharmacological cardioversion should not be done. So recommendation is class 3C. Now the repetition of this previous slide in a different manner. Rhythm control in AF, rhythm control choices in normal systolic function, no heart failure. So you can use dronedarone, flecainide, propafenone, sotalol. If these fail, you can use amiodarone or going for catheter ablation. If the patient has cardiac failure or left ventricular ejection fraction is reduced, then if the EF is more than 35, you can still try sotalol. But if ejection fraction is less than 35, the only choice is amiodarone, or you can go in for catheter ablation. In symptomatic AF, what are the indications for catheter ablation? So there are 4 categories of patient. The first patient has paroxysmal AF, second patient has persistent AF but without major risk factors for AF recurrence. Third category is patient with AF with major risk factors for AF recurrence. And lastly, paroxysmal or persistent AF with heart failure or reduced ejection fraction. So on one extreme is a patient who is relatively young and paroxysmal AF with no structural heart disease. In those patients, you can try pill in the pocket or antiarrhythmic drugs. You need not go for catheter ablation directly. But if there is patient choice, the recommendation for ablation is class 2A. If the drug therapy fails, then catheter ablation becomes class 1A. Or you can continue with antiarrhythmic drugs. If the patient has persistent AF but without major risk factors for atrial fibrillation recurrence, then you can go in for antiarrhythmic drugs, or again catheter ablation becomes class 2B indication. So you should first prefer antiarrhythmic drugs, but again if these drugs fail, then you can have catheter ablation as a class 1A recommendation. If the patient has persistent AF with major risk factors for recurrence, then antiarrhythmic drugs would be the drugs of choice. If they fail, then going for ablation. If the patient has persistent or paroxysmal AF but has a heart failure or reduced ejection fraction, then this becomes catheter ablation becomes class 1 indication, right? Or you can, second choice is you can try drugs. If the drugs fail, then again catheter ablation class 2A recommendation. Once the patient attains sinus rhythm by a rhythm control therapy, do we require to give long-term antiarrhythmic drugs? So for that, assess and treat the risk factors, comorbidities, see whether the patient is on ACE inhibitors, ARBs, MRA, statin, see whether the patient has left ventricular hypertrophy or LV dysfunction. For patients who have minimal structural heart disease or no structural heart disease, you can give dronedarone, flecainide or propafenone, class 1 indication, sotalol, class 2B indication. In case of recurrent AF, catheter ablation. Patient with coronary artery disease, heart failure but preserved ejection fraction, or significant valvular disease, amiodarone becomes drug of choice. Second is dronedarone. Both have class 1A recommendation. Avoid sotalol. If the patient has heart failure with reduced ejection fraction, then again the drug of choice would be amiodarone, or if it fails, catheter ablation. So this is the long-term antiarrhythmic therapy with patients in whom sinus rhythm had been achieved by using rhythm control strategy. Now, when do we prefer rate control or rhythm control? So factors which favor rate control, he is usually a patient more than 65 years of age, who has persistent AF, who does not have much symptoms, patient is hypertensive, no history of congestive heart failure, and patient has history of previous antiarrhythmic drug failure. So if this category of patient comes to you, prefer rate control. While relatively young patient, less than 65 years of age, who has paroxysmal AF but a lot of symptoms, or the patient has newly detected AF, or the patient has congestive cardiac failure, or there is no previous history of drug failure, antiarrhythmic drug failure, in this patient you prefer rhythm control. So how do we deal with the patient with AF? If the patient with AF comes to you and is symptomatic, and in this slide we are talking about a patient who is not hemodynamically unstable, so you can start with rate control. Start with beta blocker or calcium channel blocker. If the symptoms resolve, then continue rate control. If the symptoms do not resolve, then you can modify rate control or consider rhythm control. So when do we consider rhythm control? If the patient is highly symptomatic, has multiple recurrences, extreme impairment of quality of life, or the patient has arrhythmia induced cardiomyopathy. In those patients, consider cardioversion. If the patient has persistent AF, consider cardioversion. If after cardioversion the symptoms improve but AF recurs, then maintenance antiarrhythmic therapy. If the symptoms improve and patient maintains a sinus rhythm, then just observe. Okay, you may give oral anticoagulation. If the symptoms do not change and do not attain sinus rhythm, then continue rate control. If it is paroxysmal AF, right, we are seeing that patient who has no relief with beta blocker or calcium channel blocker, who is symptomatic and has impaired quality of life and has paroxysmal AF. If the patient has low burden of recurrence, then you can try pill in the pocket. Or if the patient has high burden of recurrence, you can consider maintenance antiarrhythmic therapy or even catheter ablation. Now, after discussing a lot of rhythm control, let's discuss the rate control therapy. Many of the drugs, many of the patients with AF ultimately land on the rate control strategy. So this is the background therapy for all AF patients. This is the first choice in those patients with no symptoms or minor symptoms. This is also the therapy where the rhythm control has failed. And lastly, this is the therapy of choice when the risk to obtain sinus rhythm are more than the benefit. For example, in a patient with a left atrial thrombus. The idea is to keep a lenient heart rate of lenient target of less than 110 per minute. If there are symptoms of deterioration of LV function or CRT, then even with cardiac resynchronization therapy, CRT-P or CRT-D, the patient still has symptoms, then try to attain a lower heart rate or lower the heart rate in CRT aimed at continuous biventricular pacing, and assess heart rate during exercise, gradually increase the heart rate but keep it to less than 110 at 25% of maximum exercise. In CRT patients, assess continuous biventricular pacing. So see whether the patient on CRT has a continuous biventricular pacing. If the patient does not have continuous biventricular pacing, we go on the next step. Perform 24-hour Holter monitoring to check for the patient's safety. In these patients, consider rhythm control or ablation if the patient has persistent symptoms, number one. Number two, LV dysfunction or tachycardiomyopathy, or in CRT patient if the patient is unable to achieve biventricular pacing, right? In those patients on CRT who fail to achieve continuous biventricular pacing, going for rhythm control or ablation. So what are the choices of drugs for rate control? If the patient first assess the comorbidities, if there are no comorbidities, no heart hypertension, no heart failure, you can start with beta blockers or calcium channel blockers. If the patient has heart failure with reduced ejection fraction, start with a beta blocker. If the patient has asthma or COPD, start with a non-dihydropyridine calcium channel blocker, that is diltiazem or verapamil. If the patient has pre-excitation in addition to AF, then ablation. Once you started this drug, reassess the patient after some time. If the patient with no heart disease on beta blocker or calcium channel blocker does not achieve the target rate of less than 110, you may add beta blocker or calcium channel blocker or digoxin. If the patient was heart failure with reduced ejection fraction, you had started beta blocker, still heart rate is not controlled, you may add digoxin or amiodarone. In severe COPD or asthmatic patient with calcium channel blockers but still the rate is high, you may add digoxin. Again, clinical reassessment after some time. If till the rate not achieved, you can give a combination of 3 drugs, or you may go in for AV node ablation. Now, long-term control, rate control. So once the rate is controlled, you have started the patient on say beta blocker or calcium channel blocker, then perform an echocardiography. After initial 1 month of therapy, your rate is reasonably controlled. Then perform echocardiography, choose initial rate control therapy or combination therapy, target heart rate less than 110, and at the same time avoiding bradycardia. For long-term therapy, if the EF is less than 40%, then only 2 choices, beta blocker or digoxin. So if you have started beta blocker, consider low dose combination therapy, yet like you may add digoxin. If you have started digoxin, later on you may add beta blocker if required. If the ejection fraction is more than 40%, you could start with a calcium channel blocker or beta blocker. I would not start with digoxin. Add therapy to achieve target rate. If the target is not achieved, then you may add digoxin or you may add a beta blocker calcium channel blocker combination. So that was all about the rate and rhythm control in atrial fibrillation. After that, in the ABC guidelines, you have seen C. So in one slide, I have tried to summarize the C, that is the comorbidities, comprehensive AF risk factor management and curtailing the comorbidities. Like if the patient is hypertensive, use guideline adherent management for hypertension. If the patient is physically inactive, optimize the exercise schedule. If the patient has obstructive sleep apnea, then diagnose it and treat it using a CPAP or BiPAP. If the patient is an alcoholic or takes a lot of alcohol, try to reduce the dose or even try cessation. If the patient has hyperlipidemia, use guideline adherent management. If the patient is a smoker, try cessation of smoking. If the patient is obese or overweight, then try to reduce more than 10% weight and target BMI to less than 27. If the patient is hyperglycemic, which HbA1c more than 10, try to control the HbA1c to less than 6.5. So that is all about the AF. In my 3 lectures of AF, I have tried to try to comprehensively talk about atrial fibrillation. So most of the aspects of atrial fibrillation have been controlled. So in next lecture, we will talk about AV and RT. So if you are liking this lecture, please subscribe, like and share.